This conference will now be recorded.
Oh, I see where it is. Okay. And Ken Anderson, I think. All right. I'm going to see. Oh, Jim Ward. I keep seeing extra people whose names I have not. So here's who I have written down, and then you'll tell me who I missed. I have Jake, Peter Kafka, Anna Moskowitz, Bill Franklin, Bob Bodiga, Dennis Correa, Dennis McGuire, Jerry Pelfrey, Larry Fish, Les Shelderup, Lopaka, Sylvester, Ken Anderson, Jim Ward. Who have I missed? Paul Frieda.
Yep. Where's Len tonight?
Good question.
You want me to call
I
him?
don't know. I haven't heard anything from him, so I don't know.
You want me to give him a call? He might have forgotten.
Yeah, give him 10 minutes. He'll be, if he's not here in 10 minutes, give him a buzz, please. All right. So I think I have everybody now. And I also think, is there anyone, I know all your names, but have any of you not been on the call before? Has anyone not been on the call before? Okay. So you've all had a chance to introduce yourself. Somebody just came in as a caller.
No, my phone got disconnected for some reason. I called in again.
Okay, so is that Lopaka?
Yes, yeah, I'm calling in from a different phone number.
Okay, not bad that I recognize your voice, eh? How'd you like that? Okay, so let me go down the list and see who would like some time. And we'll jump right in. I will give you an update on Professor Bill before we start, but let's just go down the list first. Jake, do you have anything for us?
No, not tonight, sir.
Okay. Is that the truth, or you just don't want to talk about it?
A little bit of both.
A little bit of both.
I really don't have any news, other than what we talked about a couple of weeks ago. So I won't know much of anything until I see my doctor at the end of the month.
Okay. So we're still in that abiraterone pattern?
Yes.
Okay. All right, Peter, anything that you'd like to talk about?
No, I'm good. Yeah, everything's fine. I fly home tomorrow.
Okay.
Lopaka, I'll catch you at the end of the week when I get back tonight.
Okay. Ken Anderson, anything you'd like to talk about tonight?
Nope, I'm good, thanks. Just listening.
Okay. Alan Moskowitz, anything for you?
Yes. Yeah, I do want to talk a little bit and get some thoughts from people. Yes.
Okay. Bill Franklin, anything for you?
No, I'm just going to listen in tonight. I'm good.
Okay. Bob Bodigo, would you like to? Yeah, I think you probably would like to talk to us a little bit.
Yeah, I could use a few minutes. That would be good.
Okay. And I really, when we get to you, we'll say it again, but I really want to encourage you to join Peter's call next week, because there'll be a lot more experience on there with what you're facing. But we'll come to that. Dennis Correa, anything for you tonight?
No, Rick, just going to listen in.
Okay. And Dennis McGuire, would you like to talk to us?
Yeah, I have a quick update from our last call. I don't know if you want me to give that now or wait.
No, we'll come back to you. I'm just checking to see how many people want to speak, and so I know how much time to give everybody. Jerry Pelfrey, would you like to talk to us tonight?
Yeah.
Okay, you got it. Larry Fish, I heard you're only with us for an hour. Is there anything you'd like to discuss?
No, I'm good, thanks. Thank you, Rick.
Okay. Which reminds me, I forgot to wish those of you who are of the Jewish faith, of which there are a few of us on here. I did not wish everybody, I think, a good New Year this year. I can't remember if I did or I didn't, but I do wish you all a very good New Year, and may you all be well inscribed for a very happy and especially a healthy year. And if you're fasting tomorrow night and Wednesday, I wish you an easy fast.
Can I say thank you even if I'm not Jewish?
You can say thank you, but you won't be fasting. Are you fasting?
No, not hardly.
Okay. All right. It's all right. It's easy for us. You have to go. You have to go all that time between Lent and Easter, giving something up. We only have to give up for 25 hours.
Well, I'm not a good Catholic. I try to be a Christian, but I'm not a good Catholic. I'm not even Catholic.
Okay. All right.
By the way, Len is joining us.
Here I am.
Okay.
Hey, Len.
Hello, Len.
Hey, everybody. Sorry I'm late.
Les Shelderup, anything that you'd like to talk about tonight?
Maybe just a quick question.
You got it. Lopaka, anything for you tonight?
No, I'm good.
You sure?
Yeah. I just added another doctor to the list, but outside of that, I'm fine.
Okay.
I mean, I'm not fine, but I'm good.
Okay. All right. Sylvester, anything for you, sir?
No, thank you.
Okay. Jim Ward, would you like to talk to us?
Hi, guys. I just have one quick insurance question. Hopefully won't take more than a minute.
And Paul Frieder, anything for you?
Yeah, I've got a serious issue to mention, and I'd like to see what people have to say about it.
Okay. So maybe we'll bring you up a little bit. And Len, anything for you tonight?
No, thank you, sir.
Okay. I have to check with you like I checked with Jake. Now you're sure you're not just being generous to the group?
Well, sometimes I can't remember what I told you and what I told the group. I could talk about a little bit about darolutamide if you want.
That's probably good, actually, to talk a little bit about darolutamide, because it's really important and you're experiencing it, and I think it would be very useful to the group. So yeah, we'll put you in somewhere in the middle for darolutamide. Okay, did I ask everybody? Did I check in with everybody, or have I missed anyone? Good. All right, so let's start with Alan Moskowitz, and then we'll go to Paul Frieder, and then we'll figure out where we're going after that. Alan, what's up?
Okay, thanks so much, and thanks for the wishes for the good new year. The reason I'm calling is I have to make a decision as to when I want to pull the trigger on an Axumin scan. I'll give just a bit of history. Right now, my PSA is 1.63. I expect it to go up to about 0.1 every month. Now, back 6 years ago, I had surgery. I had, and a few years after that, I had salvage radiation along with 6 months of hormone therapy. And despite that, the PSA has crept up. Previously about 0.1 every 3 months, then about 0.2 every 3 months. Now we're just at the point where we've gone up 0.3 over the past 3 months. And so I'll expect it to be roughly about 2 at the end of the year, or in mid-December when I go for my next PSA. Now, my medical oncologist, he gave me a prescription. He's fine with the idea of Axumin at this point. And I had consulted with a second medical oncologist who agreed and said, yeah, why not? and maybe I'll find a lymph node or something that could be treated. And I'll only add one more thing, is that a year ago, last April of 18, I did go to NIH for a PSMA scan, which was negative. And that time PSA was about 0.5. And so both my medical oncologists I've talked to said, well, whether you pull the trigger at 1.7, 1.8, or 2, or even a little over 2, you're probably going to get the same result, and there's not much of a difference. And I wanted to get thoughts from everyone if that's the case, and is there any other reason to wait longer to even say 2.5 or something like that? I'm on Medicare this year. I know they'll pay for at least one scan, and maybe another one in a year if I need it. And frankly, if the Axumin scan finds nothing, then I'd probably look around for another clinical trial in a year and then go back to the PSMA. So any thoughts from folks as to when I should pull that trigger, or does it not make a big difference?
Well, I'm gonna turn this over to my trusty co-moderator, Len Sierra, because it is right in the center of his wheelhouse. Len, what? And I also believe, if I'm not mistaken, that one of your medical oncologists is Dr. O. Is that right, Alan?
Yes, I saw him as well. Yes.
Yes. Okay. Well, then, all the more reason, Len. What thought do you have for Alan?
Hi, Alan.
I'm sorry, what was that?
Alan,
Go ahead, Len.
This is Len, Alan, and I also go to see Dr. O. When my PSA was 0.8 back in December of 2018, I had an Axumin scan and nothing showed up. I spent the next 6 or 7 months trying to get into an NIH trial for what's believed to be the most sensitive scan, PSMA scan, called PYL for short.
Yeah.
And well, by the time I got that scan, my PSA was 2.4, and they did discover, depending on how you count it, 3 to 5 bone mets. And that's after the Axumin scan showed nothing. I also had 2 technetium-99m bone scans, both of which were negative. One was done before the PYL scan, and one was done after the PYL scan, which revealed the bone mets, but still the traditional bone scan, the technetium-99m, that still revealed nothing. So I guess it's fine for you to try the Axumin scan at 1.6, or by the next time you have your PSA done, as you say, it'll probably be closer to 2. That's
right.
Kind of a sweet spot for Axumin. You know, it may very well reveal something.
Yeah. Okay, so that's okay. So I'll just ask you one question. I'm surprised you had bone mets, but along the way, did you ever have a high PSA above 3 or 4?
Well, I was diagnosed with 40, almost 49.
Okay, all right, that explains it, at least in my thinking. Okay.
What's your Gleason?
My Gleason originally was 4+3.
Okay, mine was a 9. So.
Yeah. So okay, that might explain it, because both these medical oncologists said to me it would be very unlikely to see much in the way of a bone metastasis. It's possible, of course, but unlikely. More likely some cancer in the prostate bed or a lymph node. I'm only doing the Axumin because if I'm lucky, if that's the right word, I don't even know, but if I'm lucky enough to find a lymph node that I could treat, I'd be really thrilled. And that's the purpose in my mind. I don't want to go on ADT sooner than I have to. And so if I can treat it, wonderful. If down the road I have to treat it again, that would be fine. And of course, if it ends up in the prostate bed and I can't treat it, well, so be it. At least I've, done the looking, and I'm trying to avoid, the regret, which is why I want to do this, and frankly, why I did the NIH scan last year. Okay, so you're okay with it, and I don't have to wait till a higher PSA, 1.9 or thereabouts. Probably okay if I'm
Sure,
going to see.
so.
Okay, very good. I'm okay with that. Thank you so much. And
What was the NIH scan that you did again, Alan?
yeah, I'm trying to remember. It might have been the PYL. I can't, it had one of those mysterious names, and I could hunt for it while we're on the phone, but I think that was it. Yeah, I think it was the latest and greatest, and at least back last April or so.
Yeah. And your PSA when you did that was, you said about 0.8, did you say?
Oh, no, 0.5.
0.5.
Right. Yeah.
Again, that's sort of, Len, isn't that at the very low end of for a 18F PYL?
Yeah, as a matter of fact, by the time I entered the trial, they were excluding anyone with a PSA less than 0.6.
Right, because they found already that the amount of positives they could get at the low levels was fairly low. I found that out myself, and that was fine. I didn't frankly regret at all pulling the trigger soon, because I really wanted to know if there was something there. And I was willing to gamble that, if I find nothing, then I was going to go to the Axumin next. And then, of course, you all know that 5 to 10% of cancers don't express PSMA. And so, I might be one of those who was going to find something this time, only for that reason.
Unlikely, though.
You think unlikely?
Unlikely that your cancer cells don't express PSMA. My understanding is that those cells that don't express PSMA are pretty aggressive, later stage prostate cancer. Would you agree with that, Rick?
I really don't know much about that, Len, so I'll go with you. But I did think it was more than a 5 to 10% number. What number were you thinking that didn't express PSMA, Len?
Oh, I thought it was a little higher than that, but I'm not sure. I don't recall.
Yeah, that's the 5 to 10 is what they told me at the time. But of course, things may have changed now in the past, 18 months or so. So, but that's the reason I'm switching to Axumin right now versus trying to get another study done with, PSMA.
Well, yeah, I mean, they can test for PSMA, and they usually do that with a PSMA scan. They do it oftentimes with the gallium-68 to see if they get a response. If they don't get a response, then they figure you don't express PSMA, and they do that as a preliminary to using lutetium for a what do you call it? Curative. What I'm thinking is that, well, first of all, Len, can you go back to NIH or not?
I suppose I can, because, well, of course, I already went back a second time for the biopsy. But when Dr. Zalewski and Dr. O were trying to decide if I should have radiation to the bone mets, they agreed not to do it now, but they Zalewski said that Dr. O told him he will negotiate with the NIH to be re-scanned, with the PSMA, with the PYL. I guess sometime after I've been on the ADT regimen.
That's very interesting. When I asked about having a follow-up scan or a scan at a later date when I was at NIH, and they told me no, not for that particular protocol. However, if I was involved in a different clinical study, then yes, I could. Also, when I spoke to the folks at, I think it was UCLA, when I was trying to assess where I was going to get that PSMA scan, they told me you could have another scan, but the FDA had I don't want to say a guideline, but I would say there was some sort of thinking that you shouldn't have more than two in some reasonable period of time. Now,
this is Lopaka, to interrupt for a second. I had my PSMA PET scan at UCLA, and it's one of the issues is outside of a trial, it's not FDA approved.
That's right.
I don't recall that. But that doesn't mean you can't have one. I paid for it. It was $2,700. You just go into the drugstore, pay for the test, and do it.
Yeah, no, but I guess the thinking was there was some health reason or some risk why you shouldn't have a second one or not more than one.
Okay, the comment that they made to me was that it's not really helpful unless your PSMA rises to a certain level. In other words, it's not really effective at the low.
Yeah, I think Lopaka, what you're thinking is not PSMA but PSA, that it isn't effective unless your PSA rises, and that's the discussion we're having with Alan right now.
Okay.
Where is he best to get his next scan? Is he best to get an Axumin scan, or is he best to go back and see if he can get another 18F PYL scan? And I think that's the issue that I would be considering, Alan. And what I might want to do in that regard is talk to Dr. O.
Yeah, I could do that and get his opinion on that. But of course, I guess, that's maybe worth a call just to see what he has to say on it. I think I like that idea. Because I'm in the mindset that until I could get into a scan, a clinical trial for a scan, it might be a while. And so I'm not sure I see a downside of doing the Axumin scan, except that, another round of PET, that's all.
Yeah.
It's not the PET that's dangerous, it's the CT part of it because of the radiation.
The CT, okay, not the PET part of it is what you're saying.
Correct. It's the CT.
Okay, I didn't know that. All right, very helpful. Thank you.
But as far as PYL or Axumin or whatever, from what I've seen, any of them, PSMA, PYL, and Axumin are all similarly accurate once PSA reaches 2 or higher.
Yeah.
It's when it's below 2 that you need the more sensitive scans.
Yeah. Okay. All right. Good. That's the number that I've heard.
This is Peter. This is Peter. I came across a study that came out last week that essentially said that it was a clinical trial that said that the Axumin scan is half as good in terms of results as the more sensitive PSMA scans.
Mm-hmm.
You get twice the readings. One wild card.
For all PSA, this one is below 2.
All of them.
Yeah, I think I saw that too, Peter. That's why I was going to ask. I was going to ask you or Lem what you thought about that, and I tend to agree that the Axumin scan is fine. It's more accessible, but if you can access a either a 18-FPYL or a gallium-68 PSMA scan, then you're going to get better results.
Yeah.
Well, there's one other thing I wanted to bring up that's a little bit of a wild card, and I kind of can shoot myself for not talking to them because I had a table set up there at the conference. I don't know if they're going to be at the conference or not, but you might want to. It's Blue Earth is a private company. This is not. I don't know. I mean, you've got to go to one of their facilities, which are spread all around, to have the scan done. And I don't know whether the radiologists are independent private guys that work for the Blue Earth company.
They're independent. At least some of them are independent, because I have one already picked out in New Jersey, and this guy has someone actually recommended him to me. He's got the latest and greatest. I think it's a GE setup, and I talked to him personally actually, and he was very nice. And what he said to me about Axumin versus PSMA. He just said that if there's a problem and there's cancer cells in the prostate bed, it was of his opinion that Axumin did a better job than PSMA. Now, I don't know whether he's quite true or whether it's very much equipment dependent, which it may well be, and that may be some of the reason that some of these results are maybe a bit unclear. Certain PSA levels.
Maybe I'm a cynic, but I think it's probably dependent on his pocketbook. I mean, I don't think there's anybody that is familiar with all the different scanning techniques that would say that Axumin gives better results under any circumstances than the PSMA scans.
Interesting. Okay.
I mean, that's my general impression. Len or Peter or anybody else who's really familiar with this stuff would do you think that under certain circumstances Axumin is a better test?
I don't think so, Rick. And I actually dug up some numbers on this, percentages. If you'll, and these were compiled by Alan Adele, who is kind of a radiation specialist. I mean, he's extremely knowledgeable about radiation, all things regarding radiation treatments for prostate cancer. And he culled this information from the literature. I'm gonna read the chart he put together here. So for a PSA range of 0.5 to 2.0, he's got F18 DCF PYL picking up 88%, gallium-68 66%, gallium-68 HBED 69%. Let's see. Then we got fluciclovine, which is Axumin, 77.8% between 1 and 2.
Right. Yep.
But only 37% between 0.2 and 1.
Right.
And hold on, let's see what else I have here. Then he's got a range of greater than 2.0, and you've got, well, he doesn't have a number for PYL for greater than 2, but for the highest gallium-68, he's got a 97% if it's over 2.0. And for fluciclovine, he's got 88.6. So there's not a huge difference there, actually.
Yeah, I remember that chart, and I know he updated it.
Oh,
I remember, I don't remember how many months ago.
Okay.
Yeah, I remember that. And yeah, I mean, that's why I went to NIH to start off. And now, well, I'm going to mull that over a bit and see if I want to switch and do a SMA scan. I'm not convinced, only because I'm concerned about being maybe a non-PSMA expressor. You know, if it's a 10% chance Well, I don't want to get in a situation where I'll regret not doing something. And so, I'll talk to Dr. Rowe. I'll get his thought on it. But at the time when I saw him earlier this year, he was very fine with the approach. Okay, I appreciate the comments. Thank you.
Hey.
Hey, this is Lopaka. Just one other quick comment. It's my understanding that the PSMA PET scan has a granularity of 3 millimeters, which is apparently state of the art. So the clusters of the cells or the cancer has to be in the lymph nodes before it gets picked up.
Right. Yeah. That's right. You mean, that I recall. I remember the number 3. I seem to have a number 4 sticking in my head, but that's close enough. Yeah, if it's all very diffuse, you're not going to find anything. Absolutely.
Okay, I think we do have a new person that's joined us a little bit late, so we'll dive in to talk to Del Jensen, who was introduced to us through Les Shelderup, if I'm not mistaken. Is that the right connection, Les and Del? Are you with us? Les, are you with us? And Del, are you with us?
Dell's microphone is on.
Les is muted.
Yeah, I can't see this with this silly setup that they've got me on here. It's very annoying. Very annoying. Well, I'll have to avoid this next time. Les, can you hear us?
Hello?
Here comes Del.
Hello, Del.
Can you hear me now?
We can hear you now.
Okay, can you see my picture?
No, but we'd like to.
All right, well, sorry about that. I was having all sorts of technical difficulties. I could get my camera to work, but I couldn't get it to work in the app. So I've been messing with that. And so anyways, so my name is Del Jensen. I was diagnosed with stage 4 metastatic prostate cancer in July of this year. I got a referral to the University of Iowa at the Holden Cancer Research Group, and I first saw the oncologist, the medical oncologist there, July 24th, and he immediately started me on ADT and chemotherapy. And so my Gleason score is 10. 7 out of the 10 biopsies were 10 out of 10. I had 5 that were 9 out of 10. My urologist said about 80% of my prostate's involved in cancer. I did have a bone scan. The initial diagnosis was July 9th. I had a bone scan the following week, and there was nothing in the bone scan. But then I asked for a referral to Iowa City. My oncologist at Iowa City basically said, well, no, surgery is not the protocol for the stage of cancer you have. And he pointed to the Stampede studies and the Latitude studies as far as that. At the time I was at Iowa City, my PSA was 220, and then after ADT, about a week later, it was 161, and then about a month later, back in August 14th, it was 58, and it's now currently 7. And so to kind of put this all into context, I am a 50-year-old male, roughly 270 pounds. I take good care of myself. I do not have high cholesterol. I do not have high blood pressure. I am not diabetic. And I would like to proceed with surgery, but I got my
I think we just lost you, Dal. Are you back with us? I'm guessing that I'm guessing it's an internet problem. Can people hear me? Is it my internet or is it?
No, it's Dell. I can't hear him.
Yeah. Yeah, we've lost you on the internet, Dell, and it sounds like it's a weak internet connection. I got a lot of thoughts for you, and we've got some great people on the line that can start talking to you. You might want to just try dialing in on the phone line. God, this. I don't even see. Is Dell still with us? I can't see on my panel. I don't see a DJ.
My connection says he's offline.
Yeah, I think he just dropped.
Mine shows his microphone is still alive.
Yeah, but he's offline, as Bill says.
Yeah, he's offline. I think we just lost him. Well, I have a feeling he'll come back. And I don't want to get into his issues if he can't hear us. Yeah, now it's just telling me he left.
Yep, he dropped off.
All right. Well, Ken, I certainly would like you to be talking to him. Carl Foreman isn't with us today. But I think we need to have a discussion with him about it. I think he does have a GU Med Onc, but I'm not certain. I'm trying to remember from the information that was sent to me. Les, can you hear us? Les Shelderup?
Yes, I can hear you.
Okay. How did you meet Del? Because didn't you introduce Del to us?
Yes.
Del's back on, by the way.
Okay. Les, how did you and Del come together?
We sat together at the last US2 meeting locally.
Ah, okay. But I remember Del is a professor at Augustine College. Is that close to where you live? Is that in the same area?
Augustana College.
Augustana, yes.
Augustana.
I think he's back on.
Yes, we see. So now we've got you back on. We lost you for a few minutes there, Del. There's a lot that we'd like to talk to you about. Let's spend the next 20 minutes or so. I don't have your information in front of me. I'm going to look for it momentarily. I know you sent it to me, and I thought I entered it, but I guess I didn't. There are probably two main issues. The first is whether you're seeing a medical oncologist that has a specialty in genitourinary disease. Are you or not?
He was the medical oncologist that I was referred to at Iowa City, the Holden Cancer Research Center. And in asking him, it seems like, yes, he deals a lot with, because one of my first questions was how many 50-year-old patients he had with stage 4 prostate cancer, and he said he only has one other patient. And so that kind of gave me the idea that this is pretty uncommon for someone my age to be as progressed as this, to have a...
Well, we have a couple of other guys on this call who are at that stage. It's uncommon, but it's not unusual.
Okay.
And so I'm going to have you talk to both of them momentarily. But my 2 cents is that it's very important that you align yourself, if your insurance allows you, with some of the best genitourinary medical oncologists that are available to you. And a lot of times, these guys who are in these smaller practices, they just don't have the experience. I was going to kick off with Ken because I wanted to talk to you about debulking, but I think rather than do that, why don't we go to Jim Ward, because he had a similar experience. But just hold on 1 second, Jim. I just want to ask you a couple of issues. How much chemo have you had so far?
I just completed my 4th round of chemo.
And how are you doing?
Very well. I'm tolerating it. I haven't missed any work. My biggest problem are fatigue and irritable bowels. I do have that, what I call burn mouth, for the first week or so after chemo.
Yeah.
I've also started exercising and working out on a regular basis. I've missed 4 days so far. I worked out my last chemo was on Tuesday. I worked out Tuesday, Wednesday, and Thursday. And then I was pretty fatigued Friday, and then I think I might try to get up and get on the treadmill tomorrow morning. But yeah, no, I'm tolerating it very well.
Well, you are our poster boy. You are our poster boy, because this is everything that a lot of us say when we try to provide tips as to how to best manage the chemo. And there's a bunch of guys on here who have done chemo before. But let me first go to Jim Ward, because Jim is similar age and started off with a local genitourinary oncologist or a local medical oncologist and switched. Jim, well, maybe you can just give Del a little bit on your background and then give him your best peer advice on how you handled your disease.
Sure. Hi, is it Dell or Dale?
Dell, D-E-L-L.
Okay, all right. Well, hi, Dell. Sorry to hear about your recent diagnosis. So we do have some things in common.
Oh, Jim, hold on a second. I think we lost him again. Did we lose him, guys?
Yes, he's offline again.
Okay. I think we're going to ask him to call in, because we've got a lot of people that he should be talking to on this call that we can connect him with. And it's no good if they start talking to us and then they talk to him and then he can't hear them.
Well, he can always go back and listen to the recording.
I'd rather he didn't have to do that. You're right. I did think of that, but I'd rather he didn't have to do that. Right. I think what we'll do, Len, what do you think? How do you think we should manage this?
No, I think we should wait for him to come back.
Okay. So why don't we, Jim, you had a short question for us. Why don't you take your short question and maybe he'll be back on by the time we're done with your question.
Okay, sure. This is one of those supremely good news, bad news things. So as some on the call know, after I was diagnosed, I began Lupron and Zytiga. And just, a couple of weeks ago, got updated labs, and PSA came in 0.1, which is great news. And then I get home to Kansas City from Houston after doing my radiotherapy down there, and I get a nice letter from Cigna telling me that Zytiga won't be covered without prior approval starting January 1st, that the medication is being taken off of my drug list. And, you know, I'm hoping this isn't something to get too panicked about, because I certainly would credit Zytiga as having probably a significant role in bringing down that PSA. And, you know, I just, you know how insurance companies are, but I feel like I need to task my GU oncologist to, you know, obviously to contact Cigna and tell them that they're idiots and that that I need to continue taking the Zytiga as long as it's working, and that's what I plan to do. And I plan to ask Paul Korn to kind of lead the charge on that, under the belief that it'd probably be harder for Cigna to tell somebody from MD Anderson to go jump in a lake. But I don't know. Has anybody run into this? It seems crazy to me.
Jim?
Well, hold on 1 second. Let me just give one thought, and then I'll let you guys chime in. What I don't think it's as bad as it sounds. What I suspect is they won't cover Zytiga, but they will cover the generic.
Right.
That's what I think is going on, Jim. So
there is a generic. I guess I was under the impression that there was not a generic.
Oh yeah. Yeah, there's a couple of generics. There are a couple of generics right now. Jake, go ahead.
You stole my thunder. That's exactly what I was going to ask him. Did they say specifically Zytiga, or did they say abiraterone?
They said your medication won't be covered without prior approval, Zytiga. And then there's another sort of column over there, and it says generic and or preferred brand alternatives, abiraterone, generic Zytiga. So I kind of read that initially as them saying we're not going to cover Zytiga, but we will cover a generic. Right. And when I called somebody at Cigna, they said there is no generic Zytiga. I'm like, okay, you say so.
They're wrong.
Okay.
This is Lopak. Hold on. This is Lopak again. One of the things you read on your letter was without prior approval. Is that correct?
That's what it said. Won't be covered without the Zytiga.
You know, I understand, but today I just had an issue, last week, where the drug was considered tier 3. However, I could go ahead and do a prior authorization, and I got it approved today, and it dropped it to a tier 2, which dropped the price dramatically. Maybe what this is saying is you just need to apply for prior approval.
Sure. I don't see any downside to doing that. I wouldn't pretend to know whether the brand name Zytiga is any better than the generics, but, you know.
Hey, Jim, it's Ken. You know, I think your approach of having Paul's staff, you know, I'd give MD Anderson a call and have Paul's staff bird dog it. Because quite honestly, I believe you're right. You know, being who they are, they'll be able to put the screws to your healthcare company. I'd try that first. I would.
Okay, fair enough. That's what I'll do. They say no to the brand name, and we'll just, I guess I'll have to accept the generic, and I'm sure that's just fine. So thank you guys. That puts me a little bit more at ease, because when I opened this letter, I wasn't happy.
Yeah, Len, do you think there's any significant difference between the generic and the Zytiga?
Well, the FDA standard for approving generic equivalents to the brand is it has to be the blood levels of the drug have to reach the same blood levels as the brand plus or minus 20%. So if the generic falls anywhere between 80% and 120% of the stated dose, it's approved. I don't know how you want to interpret that as good, bad, or indifferent, but that's the law. But anyway, we certainly know Zytiga is generic. Jake is taking generic Zytiga, aren't you, Jake?
Yes, I am.
Yeah.
It's it's funny though. It's the Zytiga list price and the abiraterone generic list price is not very much different. It's I don't think it's more than $500 or so. At least according to my insurance.
That's probably explained by the 6-month exclusivity. So the first generic company to get a drug approved by the FDA has 6 months of exclusivity. They're the only ones who are allowed to sell a generic. After the 6-month period, other drug companies making generics can jump into the market, and that's when the price drops precipitously.
Yeah, that makes sense. Thank you.
Yeah.
Yeah. Sorry, guys. I'm back now.
Okay, we're going to come right back to you, Del. But one thing I do want to suggest to you, if your internet is a little spotty, is to consider calling in as a backup.
Okay. I switched over to my hotspot.
Okay.
So
see how you
hopefully
do.
That'll work.
And if not, I think I included you on the email for this meeting, and or go to our ANCAN and the telephone number is in there, or somebody will put it in. I can't multitask that well to put this in and moderate all at the same time, but somebody will throw it in there for you.
Rick, I threw it up in the chat window and I just emailed it to Dale's email address.
Okay, so Dell's great. Okay, thanks, Bill. Thank you so much.
You're welcome.
Just before Dell will come right back to you. We're just answering a question Jim Ward had about Zytiga. I do have one question. The generic Zytiga is not the same as Yonsa. Is that right or wrong?
I'm sorry, what was the question?
I'm asking the boffins on here, Lenz and Peters and what have you.
Oh, okay. Sorry.
Yonsa, is Yonsa the same as the generic Zytiga, or is the generic Zytiga a third version?
I think Len would know this. He's dropped off at the moment.
Yeah, sorry. Yonsa is not considered a generic because it's a different formulation. The active drug is the same, but the formulation is different. And that's why Yonsa was approved to be taken with food, and unlike Zytiga. And it probably isn't much cheaper than Zytiga because it's in essence, it's another brand drug.
Okay.
Don't they call that a biosimilar, Glenn?
No, biosimilar is it's a generic for biological drugs as opposed to chemical drugs. That's a little different.
Different, okay. Yeah.
Okay.
You never hear anything about Yonsa. I mean, I never do. I don't read about it. I don't hear anybody talking about it.
No, I don't either.
So before we go back to Dell, is there anybody else that has any other input on this generic Zytiga question for Jim, or experience? Does anybody have any experience on this issue?
Just curious as to how much the bill was. Or did he get a bill? Or is it fine?
I can't say I haven't gotten a bill that corresponds to the Zytiga, but I haven't gotten a bill lately that I could put my hands on. So at this point, what they're saying is starting January 1, they won't pay for the brand name. So this is kind of looking out a couple of months.
Gotcha.
I have one other comment for what it's worth. The Zytiga, if you buy the brand name, you can get assistance from the company that makes it. Is it Janssen? I don't know who makes it, but
Janssen.
Yeah, they'll give you a financial assistance. If you get the generic abiraterone, they won't. So for example, I was getting Xtandi for free, but then when I went to abiraterone generic, I had to pay $50 a month because there's no financial assistance. So for what that's worth.
So you just reach out to Janssen and try to work something out if it comes to that. Okay. All right. Thanks. That's a good suggestion.
So, and if you're going to reach out to Jansen, give me a heads up as well, because
Okay.
yeah, I'm well connected there. I mean, just do it and then see how they are. And if you have any issues, just let me know, because we can work some backdoor channels at Jansen.
Okay. Great. That's good to know, Rick.
Okay. So I think what you're going to find is that they just want you to, they'll cover the generic. I don't know what grade it's going to be, but they will cover the generic, is what I expect. Jim, let's come back to you on with another hat on. And Del, you're with us now, correct?
I am, I believe so. Hopefully it doesn't fall out again. I can't make a call and use my hotspot at the same time, so
okay.
Hopefully my hotspot will last.
Okay. Jim, why don't your experience, your age is so similar to what Dell's facing that maybe you want to fill him in a little bit and tell him how you're doing and what you've been doing.
Sure. Hi, Del. Nice to meet you over the phone. So Rick is correct. We have some things in common. So I was initially diagnosed in December of last year. My PSA at the time of diagnosis was 210. I graded at about a Gleason 7 /8. And I immediately, like you, began the hormone therapy. Now, I initially went to a GU oncologist at the University of Kansas. I live in Kansas City. And I think he's a good GU oncologist because he immediately put me on the Lupron, and instead of chemotherapy, which maybe that's more appropriate at a Gleason 9 or 10, he put me on the Lupron and the Zytiga, and that over time started all that in. Started the Lupron in January. I started the Zytiga in March, and like you, my PSA went down over a period of just 3 or 4 months to 0.94 or 0.4, let's say, and then where this group came really provided some pivotal guidance and some sort of peer pressure, good peer pressure, is when my GU oncologist had recommended radiation treatment. You mentioned that you were told that the protocol is such that you would not have your prostate gland removed. I was told that as well because I have some metastasis to certain lymph nodes, and that seemed to be a pretty clear message that once it's outside the gland, removing the gland, I suppose, is still an option, but it just doesn't make a whole lot of sense. Others on this call, I think, could probably speak a little bit more definitively to that. But what I do know is after radiation therapy was recommended to me, I decided to go down to MD Anderson, and I just wanted a second opinion. And so I saw a GU oncologist down there. I saw a radiation oncologist down there, and they both seemed to have, their consensus was that that although removing the prostate provides about the same outcome in terms of survival as radiation therapy, they felt like and continue to feel like there's a lower risk side effect profile and a lower risk profile with doing the radiation therapy versus the surgery. And so I was convinced to just go ahead and proceed with the radiation, where this group came in, kind of instrumentally And if, you know, it's just something for you to be thinking about if you ultimately decide to do the radiation therapy, is that if you do it, sort of the gold standard is to have these fiducial markers implanted in your prostate. It helps with the real-time, you know, image-guided radiation treatment. And the University of Kansas didn't seem to, the radiation oncologist there did not seem to want to do it. I'm not even sure it was in his arsenal. And there was enough concern in this group that just really wasn't, you know, state of the art. And I ultimately decided that I wanted to give it my best shot. And so I went down to Houston for 2 months and lived down there and had the radiation treatment done basically over the months of August and September. And literally I just got back home on Saturday, and I feel good about the decision. And just before I left, my PSA came in at 0.1. Don't know if the radiation helped bring that down or not, but I do feel good, at least at this stage, about the decision to do radiation treatment as opposed to having the prostate gland removed. I think that Ken Anderson kind of had a similar experience, and maybe he can share some thoughts about that. My sense is that this group, you know, given my profile, given your profile, my sense is that this group probably would tend to favor the radiation treatment over having the prostate removed based on the side effect and the risk profile. But that's just my impression based on participating in a number of calls, you know, since the early part of this year. I'm not on every call that I try to be on. I try to be on most of them. So I think that's my story in a nutshell.
So, but before, and Del, I am going to come back to you, so write your questions down and, you know, you can fire them with everybody, but I want to just say a couple of things here before I go to Ken Anderson. Is on, often on our calls, called Carl Foreman. He's not on tonight, but he was on a clinical trial which compared men diagnosed metastatic who had a radical prostatectomy versus the control group who did not have a radical prostatectomy, and that was earlier this year. Now, we tried to, we don't give medical advice, but we do speak from experience, and the experience that a lot of us have is that if you have advanced disease, the likelihood is that you're going to need radiation and hormone therapy anyway. And so the radiation becomes a little redundant. And what it adds is perhaps best case 3 to 4% improvement on overall survival. This is based on opinions from some pretty knowledgeable practitioners. And we tried to talk him out of it, but he wanted to go with it. And sure enough, his disease was recurrent within about 2 to 4 weeks. So, and I'd love for you to talk to Carl, and maybe on the next call he'll be back with us. And if not, we can always connect you. But the other thing I wanted to say to you is that this whole concept of debulking the primary tumor is something that, in terms of widespread practice, is very recent. So traditionally, only Mayo, who did surgery, and Memorial Sloan Kettering, who occasionally did surgery and sometimes did radiation, they were really the only people that were doing this. In the last, I would say, 2 years, we found that a lot of the GU medical oncologists are recommending debulking the primary. And if they do recommend it, we tend to feel that it's an easier process for the man to go through radiation than to go through through the surgery, as I said. So that's just a little bit of sort of background. Ken, you want to chat a little with Del?
Yeah, I can, but most of the information that I would cover was probably touched on by Jim Ward. So the only thing that I would add is maybe, I didn't really hear what Dale, what was your Gleason score when you were first diagnosed? Say it again?
10, 5 plus
10.
5.
Yeah.
10 cores, 10 cores, 7 were 5 plus 5, and the other 3 were 9s. I'm assuming they were 5 plus 4s, but Dell didn't say that.
10, that's all right. So the other thing that I didn't quite hear, and I know you're in Iowa, but I didn't quite hear if you really had at the moment on your team a GU medic-onc, or you're just going to a medical oncologist. I mean, if you don't have a GU med-onc, which is a different distinction between a local medical oncologist, I would really search one out no matter where you go. So can you hear me, Rick? You sent.
I can. Del, are you still with us?
Oh. Yeah, I lost him. That's all right.
I think we lost him. So I think what we'll do is he'll have to listen to
No, I'm still here. I'm still here.
Good.
I bumped it. I bumped the thing. So how do I tell if I have a GU oncologist? Because what I have is the referring oncologist at the University of Iowa Holden Cancer Center. And how do I know? He says he's in internal medicine, and he's got listed prostate cancer, testicular cancer, bladder cancer, kidney cancer, penile cancer listed as his specialties. But is there a way I can know?
Just ask him.
Okay, so what exactly am I asking? A GU? Meaning what?
GU stands for Genitourinary Medical Oncologist.
Yeah, you should really work hard at getting one of those guys or girls, wherever you're at, on your team.
Hold on a second, Ken.
Yeah.
GU stands for Genitourinary, GenitoUrinary, genitourinary. Somebody will put it in the chat window for you, Genitourinary Medical Oncologist. Now, your guy at the Holden Cancer Center has the specialties of a GU med-onc. Do you know where he trained? Or we can look
Let
at
me
this.
take a look.
What's his name?
He's board certified in internal medicine, medical oncology, hematology oncology at Michigan State, where his fellowships. But I do know he is originally from Syria, internal medicine, United Health Systems, Rochester, New York, for residencies.
Okay, did he do any fellowships anywhere?
What's that?
Did he do any fellowships anywhere?
Yes, Michigan State and Georgia Regents University in Georgia.
Okay. So guys, I'm going to ask you to mute yourself because I can't see where the feedback's coming from today because of this silly interface that I have up here. So please mute yourself. So I think he has an interest in GU medical oncology. Is he the guy that referred you to the other fellow, or is this the fellow that you went to see who says they don't do surgery anymore? Or they don't do surgery for your study?
So he was the person I was referred to at Iowa. Originally, I was referred to a surgeon, and then I was secondarily referred to this gentleman here as being the urologist, the medical oncologist, I don't know if he's a GU, whatever. And
I got it.
And so
I got it. So My guess is that he considers himself to be a GU med onc, but he doesn't really have the fellowship and the training. And I don't think he's necessarily up to speed with what's happening. How good is your insurance?
It's pretty decent. Blue Cross Blue Shield of Illinois. I can go to Mayo if I need to. They're the closest.
Well, it's not so much Mayo. I'm not sure we'd be sending you to Mayo, but can you go to Northwestern or can you go to U of C?
Possibly. I would have to double check.
Okay, so here's what, and would you be willing to go to Northwestern would you be willing to go to Chicago for treatment?
I would definitely. I definitely consider it.
Okay, so here's what we'd like you to do for next time. See if you can get to U of C, to Northwestern, first choice.
Northwestern is my first choice?
Yeah, and we'd like you to see Alicia Morgans, Alicia Morgans, Morgans. And
Alicia Morgans.
Alicia Morgans, yeah. She is just terrific. She is very well informed.
Can somebody post that so I can make sure I have her name spelled correctly?
I will. Go ahead. I got it, Rick.
Thanks. And I'll send you a link afterwards for her, Dell. But we like her a lot. She's younger, but she's just so on the ball, and she's really well respected. There is another GU med onc there, a lady called Maha Hussein, whose name you will almost certainly hear. But I mean, I think if it were me, I would be wanting to see Alicia. And we've worked with her before, and we'll send her a letter of introduction if that's where you want to go. It should be Maha Hussein, Jake, Maha.
I'm correcting myself. Sorry about that.
Okay. That was Jake. Was that an aha moment?
Yeah, aha moment.
Okay. This is what we really want to do is we really want to get you to somebody, the type of person that we've gotten Jim Ward to. And there's no reason for you to go to Houston when you can go to Northwestern. But if you cannot get to Northwestern, then we'll talk about where you can go and, who might be in your network. But I think that what you've got to do is say, look, I need to see a specialized genitourinary medical oncologist with fellowship training. And that's if they give you a hard time. If they give you a hard time, we'll help you. Okay? If they give you a hard time, we'll navigate you.
Okay.
Okay. We're sort of running a little late now, and we've got a bunch of people to go around. But is there anybody else who would like to speak to Dell?
Yeah, I would, Rick.
Go ahead.
I have a question, and forgive me if I missed this, but you said at the beginning that you're stage 4, which means it's metastatic.
It is metastatic.
Where are you? But you said you had a scan and they didn't show any mets. So how do you know that you're metastatic? Where are the metastases?
It's in the lymph nodes. I have at least two in my pelvic region, and there are 2 up near the kidneys, near the descending aorta that are enlarged. The oncologist at Iowa City didn't ask for a PET scan, but my local oncologist did a PET scan, and that confirmed metastasis in the lymph nodes. I don't have bone mets yet. And so that is, and so that is one of the things that, one of the things I want. I mean, I understand the idea of all this, but I want, while I'm young and healthy, to be as aggressive as possible with this. And I understand radiation seems to be the way to go, but I'm also concerned that with a Gleason 10, that metastasis and hormone resistance is not far away. And I've also heard and understand that sometimes the longer you live with after the post-treatment, the longer you live post-treatment with after radiation, the more likely it is to come back in the long term. And so that's kind of where I'm interested in surgery over other methods.
Okay, so let me say this. I don't think the surgery, whether you have surgery or whether you have radiation, is going to be too much different if it's already in the lymph system. And we're not a doc, but that's what my experience would tell me. So you might have a slightly better chance. I mean, when I said to you before, you have 4% better chance. That's really for somebody that doesn't already have metastatic disease. So it was probably a little misleading to you, and I'm sorry I said it now. But for people that don't have metastatic disease, who have stage 3 disease like I did, there's a slight advantage to surgery. What we're talking about in your case is what is the value of debulking the primary. And I don't know that anybody can tell you whether surgery is going to be better or worse than radiation. I think what they will probably say to you today is it's a good idea to debulk the primary. There are certain doctors, like your doctor, who doesn't think it has any value, or certainly isn't expressing that to you. But what we see with the better GU med-oncs today is that they are recommending that their patients debulk. Now, the other thing I would say to you is this. I think that most good docs, first of all, let me say there was nothing wrong with you doing the chemo. And the fact that you've tolerated it well is a very good sign. And in the long run, it may work for you. But I think that today, most docs with your type of metastasis would put you on a second-line anti-androgen before they put you on chemo. Because what we seem to see now is that chemo is best kept for those men who have extensive metastasis at the time of diagnosis. So they'd go ADT, chemo, second-line anti-androgen, whereas somebody like you would do what Jim Ward's doing, which is ADT, second-line anti-androgen, and then chemo. Again, that tells me that your guy in Iowa isn't on top of things. He's living in an older framework, and he's not reading the literature. I don't want to be too critical, but that's the conclusion I draw. So I don't think you should be knocking yourself out about whether to do radiation, whether to do surgery. I know you want to be as you've got young kids, you want to be as aggressive as possible. That's why we want to get you to the best possible doctor, because he or she will make sure that you're doing what is state of the art. And if there are any good trials out there, they're going to get you into those trials. And what I feel right now is you're not at that place. And so what I will do is we'll send you the information. Please keep joining us on a regular basis. You're on the list. If you'd like to talk to any of the guys you've talked to tonight or anyone else that we've mentioned, we're happy to put you in touch with them. But I think that basically you're on the right path. We've just got to get you to the right docs.
Okay. I appreciate that.
Okay.
Dell, this is Peter. Did they put you through a genetic panel at all, as young as you are? Did they look to see?
They did. They did, and they sent me the results, but it didn't seem to say anything. And so I have an appointment with a genetic counselor at Iowa City, but I'm going to have to change it because it's the same date as my next chemo. And so I wasn't too concerned, but I would like to to follow up with that, but I will have a future appointment on that. They did the Guardant 360.
They did Garden 360. Okay, that's interesting. Because Garden 360 is actually it's actually a fairly comprehensive genetic panel. It's more than because what they're looking for is circulating tumor cells. And the concern that I would have with Garden 360 is that you don't have enough metastasis to show a result. And really, what I think, and Len, you're going to have to help me out here. Would a Garden 360 panel show germline? I guess it depends if they find any CTCs. If they don't find any CTCs, it's not going to show anything, is it?
They do liquid biopsies in addition to tissue biopsies. So with the liquid biopsy, they should be picking up CTCs or cell-free DNA.
Yeah, but Garden is a liquid biopsy, and what I'm saying is that if
all they did was a blood test,
right? That's a liquid biopsy.
Oh yeah, you wanted to know if it was germline.
So if it was germline,
yeah.
If it was germline and they didn't pick up any CTCs, which they may not have done, because he doesn't have a lot of metastasis, then they might not have seen anything, right?
I suppose it's possible.
I don't know why they do a liquid biopsy. Look, here's the question that you've got to follow through on, either with your doc or when. Look, first, do you have any cancer in your family? Del? Are you with us, Del?
Nah, we lost him again.
I'm back. I'm sorry.
Okay. Do you have any cancer in your family, Del?
This is my second go around of cancer. I had thyroid cancer in 2000.
Yeah.
And then my father had colon cancer in his late 60s.
Right.
Colorectal cancer. My mother had my mother was morbidly obese and she had all sorts of health problems. I know that I inherited diabetes, a risk for diabetes from my mother, and she had multiple health issues, most likely including cancer.
Cancer, though.
What's that?
Did she have cancer, your mom?
She died at 56.
Did she have cancer?
Not that I know of.
Okay. So the colon cancer is important. Here's what, again, we're not docs, but here's what it suggests to me. I don't think they did the right genomic test for you. And what I would do, if it were me, is I would repeat it with a color test, COLOR, color.com. Okay? It's a $250 test. You are looking specifically for inherited cancers, and it's done from saliva.
Okay.
And what concerns me is that the Guardant test, I don't know if they could pick anything up from your blood. I shouldn't say that. Could they do, Len, could they do a germline test, a germline analysis from blood, just regular blood?
Well, yeah, that's how germline is normally done, from a regular blood test.
Well, the color test is saliva.
Well, that's another way to do it, but certainly, like when I had my germline testing at MSK, they drew a sample of blood for that.
Okay.
Well, maybe the thing to do then, don't take as gospel what I just said or what we're saying on here. Call up Guardant and ask them if the test they did tested for germline mutations. Okay?
All right, I can do that.
And reason why we're pushing you is because there is, as Peter will tell you, there's a connection between colon cancer and prostate cancer.
Okay.
And we just want to make sure that you don't have a mutation. You don't have a mutation, a Lynch syndrome mutation. So when you call them up and ask them about your test, ask them if they tested for Lynch syndrome. Okay? And we'll talk more about Lynch syndrome next time, because we just got to move on.
I understand. Thank you.
Okay. All right, guys. Sorry, we're going to have to sort of go pretty quickly here. We've got Jerry, we've got Paul Frieda, we've got Bob Bordiga, we've got Dennis McGuire. I think that's it. Let me first go to Bob Bordiga.
Foodie's here too.
Oh, and Foodie's with us. Oh my gosh. All right, let's just check in with Mr. Foodie. Mr. Foodie, how are you?
It's an interesting question, interesting answers. So I guess I'll just cut right to the chase. I had a CT scan in September. My oncologist looked at activity in the lungs. I've had, over the years, I've had lung nodules, and so they've been seeing them, they've been monitoring them. And at one time they thought about doing a biopsy, but anyhow, on Friday the 13th of all days, my oncologist said that based upon the current CT result, that I have lung cancer, and that it was serious, it was life-threatening, and so there wasn't a lot of time, and she recommended what they thought was the best treatment, and that was immunotherapy. And then
okay, hold on, Richard. Are you saying you had lung cancer, or that your prostate cancer had metastasized to the lungs?
Good question, Rick, because a biopsy has not been done. And as Len pointed out to me the other day, there's three possibilities: that these nodules are inflammatory, it could be lung cancer, or it could be metastasized prostate cancer. But my oncologist was making a diagnosis based upon the CT scan in conjunction with a radiation oncologist. A week later, I had a follow-up phone call with her to explore immunotherapy, and immunotherapy is life-threatening. I mean, we had that call last week, that wonderful presentation, and so during the course of this call, she said, well, I want to let you know that the pulmonologist doesn't think it's cancer. She thinks it's inflammation or infection. So I have 2 points of view: one, that it's not cancer, and the other one, that it is cancer. So the people I've spoken to have said that I need to get a biopsy, a lung biopsy. And so I was in contact with my oncologist last week requesting a lung biopsy, and she put me in contact with the pulmonologist, who I've worked with for about 4 years, so she knows my lungs very well. And so I'll be having a call with her to discuss her impression on the CT scan, and why she thinks what she does, and also if she could, I wanted to find out from her about lung biopsies, and they are risky, and it's a function of where the nodules are in the lungs. So anyhow, so I'm sort of on Friday the 13th, I was preparing to die, and I mean, I'm quite serious. My mind was just, I'm going to be dying in a couple of weeks, and they wanted to start me on immunotherapy within 2 weeks. And it just did not make sense to start a treatment for something that's not confirmed. And with all due respect to my oncologist, I mean, I've since found videos on CTs and lung nodules and so forth. It's wonderful what you can find on the internet from University of Pennsylvania, University of Alabama, Birmingham, UCSF, of course, Rick. They have a wonderful video on lung nodules and biopsies. And so I'm learning how they can look at a CT and make these diagnoses. But the people that I've spoken to, all these people have had cancer experience. The Empire Caregiver team, everybody on the team has cancer experience, and some of them are medical professionals, and some of their husbands are doctors, and they've all said, including Donna Wilson, you got to get a biopsy. So that's what I'm requesting.
Let me. I want to, Georgia. We'd love to talk to you for a long time, but we've got to. We're running really late today, and I take responsibility for that. But Richard, I am just surprised that somebody like Dana Rathkopf would be recommending to plunge you into immunotherapy treatment without really knowing whether, in fact, we're looking at metastatic prostate cancer or whether it's lung cancer. I mean, the drugs are different. How do they know which drug to give you? So, I 100% agree with Donna, with Len, and with anybody else who said, you got to get a biopsy. We got to figure out what the hell there is before we start treating you.
Yeah. So, yeah, it's I want the biopsy or something to that effect. There's a bronchoscopy. There's needle biopsy. There's a bronchoscopy. So there's some things that can be done.
Yeah. When are you seeing the pulmonologist?
It'll be a telephone call. Rathkopf responded to my email for a lung biopsy last week and encouraged me to reach out to the pulmonologist to find out what her impression of the CT scan was and what her thoughts are on lung biopsy based upon my underlying lung condition. I've got COPD.
Right.
So that was just the end of last week. This has all been moving pretty quickly. It hasn't even been a month since the Friday the 13th, but so I contacted Kaplan last night, and I heard from her office assistant that she's doing rounds at MSK. She's not available this week, but she'll be able to talk to me next week. When a doctor works rounds, I guess it's very intense. So anyhow, but I'm sure if Kaplan can reach out to me, she will. She's an excellent doctor, and she's
okay.
Yeah, and then so I have an appointment on Friday with Rathkopf, and Len has agreed to be there. So
fantastic!
If we can get this appointment moved to after 12 noon, and that's I'm so very grateful to Len for that, because as you can imagine, when you hear this news, it's like, oh my! And since the 13th, my mind has just been
right.
So.
What's going on with your kidneys, man?
The kidneys are fine. The CT scan said that everything looked good. The CT scan also said, there's Dr. Breitbart at MSK said every follow-up you're going to find out if you're better, the same, or worse. So on Friday the 13th, I was better. I had radiation for new tumors from small cell cancer around my prostate gland in the lower abdominal, that they were significantly decreased. And what was the same is my bone mets are the same. They've been the same now for about 3 years. I've got two of them, one in the sternum and one in the hip. They're small. And what was worse is this activity, this lung nodule activity, which was causing great concern. And
are they still seeing small cell activity, or are they not seeing that now?
What do you mean by that? Are they still
Well,
seeing?
they suspected your cancer had morphed, and so you did this carboplatin plus etoposide, correct?
Correct.
And what have been the results of that chemo regimen?
Well, since they had the combination of chemo plus radiation, they don't know cause and effect which was the most successful. They believe that the significant decrease in the tumors around the prostate gland and the lower abdominal are probably more from the radiation than from the chemo. But, you know, I don't know how they assess that. But anyhow, so rather than having me start immunotherapy last week, she had me do another chemo treatment with carboplatin and etoposide. And she decided she wanted to do another one in October and then do another CT scan maybe in November and see what the activity is.
So what radiotherapy did you have? I knew you were getting the carbo and the etoposide, but I didn't know that they were, I guess, yeah, 5 sessions of abdominal RT. I see that now, yeah.
I think it's probably, I was asking Len about this, it's called radiation precise or something like that. I think it's probably like comparable to CyberKnife.
Yeah,
you know, 5 consecutive days. And the radiologist had said that, you know, they could always go back in and do some more if it was necessary. So I thought that was fine. But he did both the gland, the prostate gland. I still have mine, and they did all the new tumors. So he did both, the old and the new.
I just wonder, Len, I mean, this might be something to figure out, but whether they see on a biopsy, whether they see the morphing, the small cell-like disease retreating and being taken over again by adenocarcinoma, or after I'm talking about after doing this carboplatin and etoposide.
Yeah, you know, as Richard said, we're going to meet with Dana Friday. So I think, being that we're pressed for time tonight to get other guys on the call, I think it might be better for Richard to come back next week after we've spoken to Dana, and we'll have more information, and we can make more sense of what's going on.
Yeah. I mean, I guess my question for her is, how do you know if the carbo plus etoposide is working? That's it. All right. Anybody else want to say anything to Mr. Foodie before we move on? Okay. Let's go to Dennis McGuire. Dennis, you're up.
Hi. Yeah, since our last call, based on Len's recommendation, I'm scheduled for an Axumin PET scan on Thursday at Sloan Kettering. And then I'm seeking approval for a PSMA scan at the University of Wisconsin. So that's in process.
Well, Dennis's PSA is pretty far north for Axumin to probably pick up something, right? Dennis, what were you at, 6?
7.
Yeah. But it's good to have both.
Yeah. And you said that you did. I can't remember where you are. Are you in
Madison, Wisconsin?
You moved to Madison, didn't you? Is that right?
Yeah. I live in Madison, Wisconsin, but I'm continuing to see Dr. Michael Morris at Sloan Kettering.
Right. Okay. Yeah, I got it. I was that was what was confusing me with the Wisconsin and the so you're doing the Axumin, or you've done the Axumin?
I will be doing the Axumin Thursday at Sloan Kettering.
Oh, okay.
This week. Yep.
Okay. What your PSA last time, it was Nate did at 1.5 and then it was going to, it was now at 2.0, is that right?
No, it's at 7.
Oh, it's now back up to 7.
Yep.
Okay. Okay. So, Dennis, you're another chap that has something in common with Dell, and with Jim, right? You're diagnosed age 50. I'm sorry, I should have
That's
brought
correct.
you in before. Yeah, I should have brought you in before.
Yeah, that's correct.
Never hesitate to speak up or shout out or something if you want to chime in, because you know your input is really helpful to these guys.
So if they're still listening, I'm 4 years into it, and my diagnosis at age 50 was very similar to what I heard today.
Yeah. Okay. Well, I'll probably try and connect you all later on, and then you guys can exchange your telephone numbers, do as you will, and compare notes offline. I guess what we're doing right now is just trying to see whether your disease has increased at all. That's the purpose of these scans, right?
That's right. We're going to try to determine what's causing the PSA to increase.
Yeah. Okay. And how quickly is it rising?
Oh, it's up. It's probably up 30% over the last 2 months.
Okay. Len, did you want to say anything to Dennis?
Well, no, Dennis and I have been communicating by email or phone. So, you know, I'm aware of what he's doing. I think he's following the right path.
Great.
Yeah.
Thanks, Len. We appreciate it. Anybody else have anything to say to Dennis? Guys, don't be shy to speak up, because it's the peer advice that counts for so much here. And if you feel like you have similar experience, it's really important to make your voice heard. Okay. Dennis, we'll talk to you soon. Let us know how this Axumin scan does, and I guess then, did you say that that you're talking to University of Wisconsin about a PSMA scan?
Yes, they're seeking approval for me to be enrolled in a trial.
Would that be with gallium?
I believe so.
Okay. All right. Well, I'm sure. And you're seeing a GU medical oncologist at Wisconsin now, yes?
Yeah, I am. I have been seeing him for my routine checkups, like my 3-month Lupron shots,
right,
and periodic blood work. But I would say my primary is Michael Morris at Sloan.
Right. The reason I ask is that when you see, I assume you're going to see Morris when you go in for the Axumin, is that right?
Yes, I see him on Friday.
Ask him, maybe you'll see Len and Foodie in the waiting room. I don't know. If you guys will be there at the same time. I don't know.
Yeah, we'll go for lunch.
Yeah.
Len, when are you there?
Well, we don't know yet. Richard Foodie is still trying to nail down an appointment time with his oncologist.
Okay.
But it'll be
all right.
sometime
I'm there midday. I believe it's at 11:30, but that means anywhere from 11:30 to 2, I'll see Morris.
Yeah, we may very well be there at the same time. I'll keep in touch.
Okay.
Yeah. Okay. Great.
What I was going to say to you is that, Wisconsin is now an NCCN hospital. And they have a history of good prostate cancer care. I think it's where Chuck Ryan originally started. So you might want to ask Morris who he likes at Wisconsin, so that you can be working with, the two guys. Check with him who he likes at Wisconsin.
Okay, that's a good idea. Thank you.
And if you don't get a name, I'm happy to send a note to Chuck Ryan at University of Minneapolis, because he definitely will have a name for me, I know. Okay?
Okay. Very good. Thanks, Rick.
All right. I'm sorry to rush you guys through. Let's move on to Paul Frieder, and then Dennis Palfrey, and then Les. I think Les Les is still with us. Paul, you had something serious, you said.
Yeah, I'd like to get some comments, but I don't know if there's anything anybody can say. Anyway, for the last couple of weeks, I've been having really awful abdominal pain in the middle of the night. Lasts for like 3 hours. And finally saw the doctor. And today I had a nuclear scan. I lied down for 2 hours under the camera after they injected some nuclear material in my arm. And it looks like my gallbladder's not working. They couldn't even see any activity with the gallbladder. So it looks like I'm up for gallbladder surgery sometime soon. I'm going to see a surgeon on Thursday, and hopefully he'll schedule me, within a few days. So anyway, that's something new. I've been dealing with it for a couple of weeks, and each time I thought, well, okay, I'll stop eating nuts, and okay, I'll reduce my fat, and then I won't eat after 6 o'clock, and none of it stopped it. So the scan showed that my gallbladder is in trouble. So.
Well, we're all sorry to
to
hear that.
laparoscopic surgery, because you recover from that more quickly than open.
Right. Anybody have any experience?
What's that?
Does anybody have any experience? Hold on. Wait. Does anybody have any experience on gallbladder surgery? Somebody does. Who was that?
Dennis, Korea.
Hello, Dennis.
Hi. Yeah, I had the similar situation this prior to getting my diagnosis with prostate cancer. But I know the excruciating pain that it causes, and you certainly will feel a lot better after. I did, and it went laparoscopic, and it was a pretty quick deal.
Good.
How long was the recovery, Dennis?
Maybe a few days.
Oh, really?
Yeah.
You have to modify your diet, Dennis, after the operation?
Yeah, a little bit. They said, avoid a lot of fatty foods, which I wasn't really doing to begin with. So that made a little bit of change, but not much.
I think that one of the reasons I got this is that I've been doing keto on and off for about 5 years now, and I think just focusing on very high fat foods has led to this problem. And I haven't ever heard anybody say there are dangers with keto diet. But so anyway, I'm just a submission on my part.
When you do the keto diet, does that include fasting then?
That include what?
Fasting.
Well, no, the fasting was something I've just actually recently started. But that keto, I've been eating lots of meats and cheeses and all the things they recommend on a high fat diet for a long time, and I suspect that this is what has brought it on for me.
Oh, this is Jake. I had a laparoscopic gallbladder surgery 20
Did you?
Yeah. And laparoscopic is definitely the way to go. Watch out for your fatty food for at least for a
Hello?
little while. Somebody says something?
Yeah, everybody goes quiet. I think we've lost everybody.
Can you hear me?
Well, I can hear you.
I can hear you.
Okay. Rick's talking to himself, I guess. But the only thing, it took like Dennis pretty much covered it, but it took me 3 or 4 days to recover. The big thing to watch out for is try not to sit on like a low sofa. You need to use your abdominal muscles to pull yourself up with, because that's when you're going to feel it.
Say that again. Try to do what on a sofa?
Well, anything low, like a sofa or something that's low to the ground, where you use your abdominal muscles to pull yourself up.
Right.
You don't have any abdominal muscles after for a while.
Oh. Okay. All right. Either of you guys have an experience of eating too much fat? What happens if you eat too much fat after the surgery?
Yeah, it runs through you.
What?
It runs through you.
It runs through you.
Yes.
Oh, okay. But you don't end up with 2 hours of excruciating pain in the middle of the night anymore.
No, not me.
No. Now, like Jake says, generally you can tell when you relieve yourself and your bowel movements. If the stuff is floaty, sometimes that's a sense that you've had too much fat in your diet.
Right.
Okay. Okay.
Okay.
Thank you.
Good luck, Paul.
Thanks. Thanks.
Can you guys hear me again?
Yeah.
Yes, we can.
Yeah, we always heard you.
No, I was just thinking about that keto diet, and I think the keto diet is a tricky thing. I mean, when I think of the keto diet, it includes several days of fasting as well, which I think is kind of the point of it, that you're trying to burn up your fat reserves. I don't know whether, Paul, what you were talking about is the keto diet or the prehistoric diet or what have you, but I did think the keto diet was a fasting diet.
No, I'd never heard that sort of thing. It's just a high fat diet that makes your body get used to burning fat, and so then that's how you lose weight. I never heard it associated with fasting.
Yeah, especially with respect to cancer, there's a lot of theories around the keto diet, which include part of the regimen is that you fast before you do chemo, or you fast as part of the regular diet. So
usually, Paul, the pain that you get from gallbladder is like an hour to an hour and a half after you've eaten. But you said it wakes up in the middle of the night?
For me, it was the middle of the night. I wake up at, I don't know, midnight or 1 o'clock, and it just lasted for a long time. I mean, minimum 2 hours. I had actually 6 episodes, and the shortest one was 2 hours, and one of them I think was 4 hours. It was just, I mean, I was saying things like, I want to die. I mean, it was just the most awful thing I've ever gone through. And, I tried everything. I'd take cold shower, take a hot shower, walk outside, try to do some exercise. I just couldn't make it go away. It was just awful.
I actually thought I was having a heart attack. I went to the emergency room one night because right after, like an hour and a half, 2 hours after supper, I thought I was having a heart attack, even though it was right-sided pain. I went to the emergency room, and that's how they found out that I had gallbladder false stem cells.
Yeah. Well, I thought about going to the emergency room. I really should have done it after the third event.
I want to cut you off because we're late, and
okay.
As interesting as it is to talk about gallbladders, it's not so much the focus of this call.
Okay.
I encourage you and Jake to reach out to each other offline. I really do. Bob Bodick, are you still with us, Bob? Hello?
Nope. He's gone.
He's gone.
Okay, I'll be in touch with him.
Hey guys, sorry to interrupt. This is Jim Ward. I have to hop off the call. I hope everybody has
Thanks,
Everybody have a
Rob.
good evening.
Okay, and last but not least, Jerry Pelfrey. I see you there, Jerry, but we don't hear you.
What happened to Len and darolutamide?
Oh.
I'll have to wait till next week, Larry.
Which is why I stayed on the call for an extra hour.
Me too.
Oh boy. Okay, Larry, in one sentence, I've been on darolutamide a month, minimal side effects compared to other ADT regimens. I love it. End of story.
Thank you. Now, how do I convince Karen Audio to buy this? Okay.
Talk to her. Just talk to her.
Do I have to switch to Dr. O?
Maybe.
We'll come back to it, Larry. I'm sorry. This has just been. I have not done a good job managing this call today. I'm so sorry.
What are you going to tell us about Bill?
Yeah, Jerry Pelfrey, are you with us? I see JP. Is that you, Jake?
No.
So, all right, I'm gonna have to send him a note as well. Okay. Yeah, Bill's going downhill relatively slowly. He's pretty much bedridden at this point. He does enjoy calls, so do feel free to call him, but how long you'll have him on the line, he'll tell you when he's had enough, but he likes to hear other people's voices. I haven't talked to him for a couple of days. I did speak to his brother at length this morning. I don't have a lot else to report. He's not in pain. Things are just slowing down. And I think he's kind of reconciled to it.
Well, at least he's not in pain. That's one good thing.
Yeah.
Not in pain, and he's mentally he's at peace. So he's doing all right.
Yep. So, but he can't really get out of bed. He's basically got to do everything in bed, and that poses some issues, but they're working around it.
Is he still on hospice respite, or is he at hospice?
No, he's home. He's home.
Okay.
Yeah. Yeah, he's back home. And, I think he's going to be with us for a while. I would think at least, 4 weeks maybe. But we'll see. So, one last call for Jerry Pelfrey. Are you there?
I had to go on to my phone. Somebody muted me.
I'm not guilty because I got a
it wasn't me.
You're showing as unmuted, Jerry.
Yeah, I know, but nothing went. So I just closed out of it, and I'm on my phone.
Okay.
So real quick, because we're in a hurry, as you know, I was diagnosed Gleason 9 in March of this year. I just got my beginning of this week. I just got the last blood test, and my PSA is 0.1 now. So basically, Dr. Singh has said, I'll see you in 6 months unless there's something that goes bad. And he turned me over to Dr. Shields, who is the chief of radiology oncology at Mayo. And we met with him today talking about radiating the prostate. I'm 73 years old, and the standard is if you're 70 or older, they do not do any surgery, at least at Mayo. So we don't know exactly what's going to go on, and I had a question on that. But first of all, I'm scheduled for a urologist to do a cystoscope. They think I might have a polyp in my bladder, but I've got a thickened bladder wall. And then I'm scheduled for a gastroenterologist because in the lower part of the colon, right before the rectum, they also saw some thickening of the wall. And I guess I pushed it a little in both the urology and the oncology because, and not oncology, on the cystoscope, because I just like to get that cleared up if there's any issue at all. But it's screwing up the capability. Dr. Shields doesn't want to do any radiation until, if they do go into the bladder, he wants that taken care of and make sure it's, I don't know, if they do surgery or something, that, you know, I get over that and I'm completely healthy again. And then he said the same thing for the colonoscopy. So he doesn't want to do, and he said it'd be about 4 weeks, and we can't do SBRT. We're going to be doing EBRT, and because of what they're doing with the bladder, he didn't think he could put in any markers or seeds. Seeds that he said would go right out. So let me throw it up. I'm more concerned really with the side effects of having this radiation, and I'm going to have it done with the proton, not the photon. So I'll throw it open. What do you think, and what side effects can I expect?
So here's my question to you, Jerry. I mean, you know, we were talking about this extensively earlier on in the call.
Right.
And it would have been a good thing to bring it up because it would have given us a different perspective. I'm going to play devil's advocate. Why are you so eager to have to debulk your primary?
Actually, that was Dr. Singh.
Oh, right. Okay.
So
I would go back to Dr. Singh and ask him the question then I just asked you.
Well, that's on the bone scan that we did. That's really the only area that I have any cancer left.
Well, you know, there's good reason to do it. As we said, up until a few years ago, they never did. But
right.
What concerns me is that you have a lot of other issues, and so you might be a lot more at risk than somebody like Jim Ward or Del Jensen to undergo that procedure. And what you don't want to do is you don't want to cause more issues for yourself. So I think Dr. Shields is probably being rightly conservative to see if to try and have you take care of all your other issues first and then sit back and say, well, maybe we need to look at the possibility of debulking the primary.
He says that they don't do that anymore in Mayo, none of them.
Do what?
Debunk the prostate unless you're younger than 70.
Okay, but well, I guess I'm maybe not using the correct term. When I say debulking the primary, I'm talking about treating the primary gland. Debulking the primary is not just in my book surgery. It's also radiation.
Oh, okay.
Basically, what you're doing is you're removing the primary tumor, and originally when they said debulking, they meant cut it out, which is what Mayo always used to do. But now, when they talk about debulking the primary, you can do it with radiation as well as with surgery. It's not quite as literal. So,
well, I guess what's happening now is we're waiting. I go back to Mayo on the 15th to talk with the urologists and actually probably do the cystoscope that day. And then he being Dr. Shields, wants the doctor that does the exam to call him right after. He wants to have a conference, I guess, with the urologist, which is fine with me. But at some point, I guess, I am going to ask about the short-term and long-term effects of this. In this case, it'll be proton type of radiation. Has anyone else had proton radiation to their prostate?
well, Les has to the abdomen, and so has Peter, but to the prostate, probably no one on this call. Anybody
All right.
on this?
What about then just photon, regular X-ray?
Well, I mean, I had seeds and IMRT, image modulated, which they might still do. Who else has had? Len, you had regular. You had regular
IMRT.
Yeah.
Yeah, but the hype, at least, is that proton beam therapy, especially the newer pencil beam proton therapy, is supposed to have fewer side effects than the other forms of radiation.
That's what I've read. What I've read.
I'm not sure there have been enough long-term studies done yet to verify that that's true, but that's the theory. And in theory, the proton beam hits the target and then stops. It doesn't continue.
Right.
So I doubt if the side effects would be worse. I don't know if they'd be any better.
Yeah. Okay. How long is this modality, or well, I shouldn't say this modality, the exam, the proton, how long has it been around?
Believe it or not, I think it's been around a couple of decades. But the newer form of proton beam, the pencil beam, I think is more recent, maybe in the last 5 years.
Okay, so it's not a new modality at all. It may be a new technique.
Yeah, they've made refinements. I think Loma Linda was the first proton beam facility in California, and I think that was late 1990s.
Okay. Well, so it looks like I'll be going really just through an exam with the urologist and an exam with the gastroenterologist. And then Shields said he would, at that point, we'd have the discussion on how we wanted to pursue the radiating the prostate. So I think that's the way we're going right now, at least. But for my 2 cents, I don't think really I've got a problem with any of it. Just the wall is thickened, and that was the differential diagnosis from the radiologist in Prescott, Arizona. So I don't know how much faith I put in that, but I will put in a lot of faith in Mayo when they go, and if they want to do a cystoscope. So, that's where I'm at. I mean, I'm in good health. I feel good. My PSA keeps going down, and now it's 0.1. So, Rick, to your point, I guess, I can, I can, as a matter of fact, I remember Dr. Shields saying that it wouldn't hurt to wait a while and see if we get a nadir on the PSA, or if the PSA keeps going down, it sounds like he might wait.
Well, look, you're on Lupron and abiraterone right now, correct?
Yep.
And your PSA is at 0.1 or less than 0.1?
No, all they said was 0.1.
Okay. So I would say you're doing pretty good. Yeah, we can see some cancer there, but that cancer may respond to the Lupron and the abiraterone. I mean, you can always debulk down the road a little bit. I know, Ken Anderson, you did it after about 2 years, didn't you? We always have to wait for Ken to tell me.
Sorry. I just looking for the on. I did it. Let's see. The first year was chemo and Lupron. Actually, I did it the second year, ended in November. Yep. So it was the end of the second year that I completed it.
Yeah. So, I would get your other health issues sorted out. I wouldn't push so hard. And maybe there is some sense now that the other stuff is resolved to do it. But if it was me, I'd take my time.
Yeah. Well, Rick, I'd like to get back to around Tucson.
You'd like to get back further south than Tucson. That's what you'd like to do.
Well, I can't deny that.
I know.
I may have to stop at Tucson on the way, though.
Well, Tubac. You'd have to stop in Tubac. Well, Tucson so you can see Dennis, and Tubac so that you can see me. And then I'll put my little skull on the top of my car and come down to San Carlos and visit you, because I understand I can row down there. So.
Yeah.
I am so thrilled about your situation, Jerry. I think we all are, especially given where you were when you first started talking to us, which was, last August, September.
I think it was more like April or May
of this year. Is that right?
Yeah, I think I got a hold of you guys pretty quickly.
Okay.
Maybe I didn't. Maybe I didn't. We were going through a lot there in March and April.
Right. No, you saw Sing in April, and we spoke to you before you saw Sing. So my guess is it was probably, we'll split the difference. We probably started talking to you in February, March, something like that. But I'm just so happy that you have such good success. You're getting good treatment, and relax a little bit, smell the roses, and and then see where you go next. Okay.
Okay.
This has been a bit of a marathon, and I haven't been with it as much as I usually am today. So again, I'm sorry, guys. All right. Well, for the stragglers that are still with us, thank you for hanging on. And Len, can you just hang on for a moment afterwards? I just want to chat with you.
Okay.
Thanks, Emil. All right, guys. We'll see. The next meeting will be next Tuesday. So just a quick reminder again. Our Tuesday meetings are the 3rd and the 5th Tuesday this month because of the calendar anomaly. Our next meeting will be on the 15th, and then the last meeting will be on the 29th. Okay? Good night, everyone.
All right, thanks, Rick.
Okay.
Thanks, guys.
Thank you. Thank you. Good night.